it depends on how quickly a team can intervene to potentially restart the heart, and also the expertise of the team providing that procedure. Generally, patients at home who have a cardiac arrest, where their heart stops, there's a delay of time before the cardiac arrest is recognized, before CPR is initiated, and before 911 comes. So the longer the delay before CPR, and the fewer the health professionals right there, that increases the likelihood that the CPR will fail to restore a blood pressure and pulse. And if it's successful, there's a higher likelihood that there will be substantial brain injury from that lack of oxygen. The oxygen is carried to the brain by the pumping of the heart. It pumps the blood to the brain, so that when the heart stops, there's not a flow of oxygen to the brain. So the success rate of CPR isn't like what you see on television, and it isn't like what you see here in the ICU, in the intensive care units. Even in the most optimal circumstances in the ICU, where you've got trained health professionals and they recognize the cardiac arrest within seconds, the success rate is not more than 50 or 60%. That success rate dramatically declines the further away you get from the ICU. So they've done studies of the success rate of CPR in, say, Oakcrest. This is an actual study done by Johns Hopkins. Oakcrest is a large retirement community, and they're set up, they have teams, and they have good relationships with 911. The success rate of CPR in that population of patients, much like my practice, and much like your practice, Ken, was about 8% of the patients actually had a blood pressure and pulse restored. That's exactly what people say. I thought it would be more. That's because you see on television how easy it is and how much they come back and it's just like that. Or you think of the successes that you've heard about in the hospital, where it's 40 to 60%. But that's because there's instant recognition and instant response with a skilled healthcare professional. And of those 8%, this is the Hopkins Oakcrest study, less than 1% of the total people getting CPR live 30 days. Imagine why your heart stops. It's because something bad has happened to you. Something bad has happened to the point of stopping your heart. And so the 30-day success rate reflects the underlying condition that led to the cardiac arrest in the first place. So as I say to my patients, less than 1% is not nothing. And for those optimists, I would not stand in the way of you having that less than 1% chance to get a pulse and blood pressure restored, and you would survive 30 days. In the Hopkins study at Oakcrest, of the 500 and some patients, there were 3 or 4 that actually lived 6 months or more. But the catch was they lived at a higher level of care with a higher level of needs than they did before the cardiac arrest. So there is a chance of survival. It's a real chance of survival. But the odds are of surviving in the way you were before the cardiac arrest are pretty small. So that's the sort of background on CPR. The last one I want to talk about from this list is nutritional assistance. The value of nutritional assistance varies by diagnosis, as you would guess. I have a few patients who have had head and neck cancer. They have a feeding tube as part of that because they have trouble swallowing from their head and neck cancer. That feeding tube is integral to their treatment and has great benefit in terms of prolonging that person's survival. I also have patients who are tube fed because of difficulty swallowing because of advanced neurologic conditions, either advanced Alzheimer's disease or advanced Parkinson's. Tube feeding doesn't reduce the risk of aspiration in those cases. No. Think about it. Much of what we swallow isn't the food we put in our mouth, it's our own saliva. Well-hydrated patients make probably 3 to 4 liters, a lot of fluid, in saliva. We're swallowing that saliva as part of our normal dental and mouth and throat hygiene. That's the normal function of saliva. So if I can't swallow because of my advanced Parkinson's disease, I have trouble, whether I have a feeding tube or not, and have trouble handling those oral secretions. So the rate of aspiration comes down a little bit, but it doesn't go away with a feeding tube. So if you thought a feeding tube avoided aspiration, well, just think about all that saliva and about the mouth contents that still have to be handled. That's why, and forgive me, this is pretty graphic, forgive me, that's why patients who have these advanced neurologic conditions drool. They have trouble handling their secretions. So if they're not in the right position, that is sitting up, head forward, if they're lying back or if they're sleeping, they don't swallow safely, and so they aspirate. And so their risks of pneumonia are still substantial, even though they have a feeding tube. So the feeding tube itself also has its own risks. It has risks of infection because you've got a tube coming through the side of your stomach, your abdominal wall. There's risks of blockage and deterioration of the tube, so it has to be changed. And the tube feeding also has a quality of life implication in that patients who have tube feedings are basically tied down to the mechanism by which the feeding is delivered. So sometimes patients will have tube feedings that are administered by pump over a period of 12 or 16 or 18 hours a day. That's being tethered. And if they're mobile, they may not wish that tethering or that restriction on their activity. So it could reduce a person's quality of life. Having talked about tube feedings in this way, you would think I was opposed to them, but it's not my decision. It's the family and the patient's decision. So it is something for you to think about and give guidance to the doctors. I usually don't stand in the way of patient and family choice about these matters, but I do feel like it's my obligation as the health professional to give advice and my opinion about this. But I wouldn't stand in the way of a person's desire for this nutritional assistance. For patients who have advanced diseases, such as cancer, the nutritional benefit of tube feedings is also in question. This may, again, seem like, geez, that doesn't seem right. I'm putting in calories. What happens to those calories? Well, for patients who have advanced cancer or advanced chronic diseases, the body mounts an inflammatory response to the presence of the cancer or to the presence of these chronic diseases. Those inflammatory chemicals that circulate in our body.